Hello everyone. So today we will be discussing rupture uterus, abruption placenta and scar adhesions, how to differentiate all these three on the clinical basis. Okay. So it is very simple. Just we need to know some concepts and we will able to solve all these clinical questions. Okay. So let's start the video. Okay, now first of all, what is rupture uterus? Okay, rupture uterus is when the patient is in the labor, the uterus get teared off. Okay, फट जाता है जिसे हम कहते हैं, uterus get teared. Okay, so most commonly it is seen in previous cesarean, but yes, it can be seen in multigravida patients also. Okay, not necessarily in previous cesarean, but yes, in multigravida patients also. Now, how we will come to know clinically that this uterus has ruptured? Okay, number one sign is that when the uterus will rupture, the abdomen, sorry, the fetus and the fluid all will come into the peritoneal cavity, right? So the fetal heart rate sound will be absent. Okay, because fetus will expire, right? Fetal will die, so fetal heart rate sound will be absent and it will be a IUD. Okay, now the second thing which we have to remember is that fetal parts, they are felt superficially. Okay, because the fetus is lying in the peritoneal cavity and all the fluids, they have come into the peritoneum. So now the fetal parts, when we will palpate the fetus, now there is no myometrium layer. Now there is no you can say now there is no myometrium layer. Now there is no uterus layer in between your hand and in between the fetus. Okay, there is only the skin in between your hand and between the fetus. So now the fetal parts will be felt superficially. This line is very important to differentiate rupture uterus from abruption placenta. Okay, now as I already said you, the amniotic fluid will come into the abdominal cavity. So now the fluid will be in the abdomen. Okay, and the rupture uterus, it bleeds a lot from the site of rupture. Okay, so there will be a lot of blood, there will be a lot of amniotic fluid in the abdomen. So when we will do ultrasound, or when we will feel the fetus, as well as we will feel the fluid in the abdomen, along with the fetus, as we feel in the ascites. Okay, now number fourth is there will be loss of station. This is the finding which we will get on the PV. The three findings are the findings which we get on PA, per abdomen. On per vaginum examination, the finding which we get was loss of station. What is loss of station? Loss of station means that loss of station means that when we do the PV, we feel the where the presentation is. Okay, first we were feeling, but as the rupture occurs, the fetus has gone into the peritoneal cavity. Now we will not be able to feel the fetus, or on the PV we can say we are not able to feel the presenting part. That is known as loss of station. First we were able to feel, but after the rupture of uterus we are not able to feel. So this is the number 4 point, loss of station, or you can say presenting part not felt. So these are the 4 points or 4 signs which indicates the rupture of uterus has occurred. Okay, so needless to say that what is the treatment of rupture uterus? We have to open the abdominal, we have to open and go into the peritoneal cavity and stitch the uterus. So laparotomy is the answer, followed by stitching the uterus. Now let's see what all question comes and how we get confused. So this is the first question. Pregnant woman brought to emergency room with pain abdomen and hypotension. Now, as I already told you that the rupture uterus, there is lot of bleeding from the site of rupture, from the site of the tear. Okay, so now there will be lot of bleeding, so the patient will go into the hypotensive shock. Okay, on examination there was abdominal distension. Yes, there is distension due to the fluid which was there. Fetal heart rate was not felt, and fetal parts were felt superficially. So the most important, I told you the line is, fetal parts were not felt superficially. The most probable diagnosis is, so I know that now you know that most probable diagnosis is rupture, but after a few seconds we will learn how to diagnose it from abruption. Okay, first of all, the third option here is IUD. Yes, IUD is there, but in rupture uterus is the condition, more diagnosis. IUD is one of the diagnoses, but now the fetus has come out of the uterus, so it is not an intrauterine death, it is something rupture uterus. Then last is obstructed labor. Obstructed labor has sign and symptoms of dehydration, and mother get exhausted, and vagina is dry, so no symptoms, signs like that, so it is not obstructed labor. Okay, so let us see what is the next question. The second question which they give is like this: Gravida 4 para 3 life 3 presents with labor pain. On examination, the cervix was 5 centimeter dilated and doctor was not able to feel the presenting part. Again, here they have given doctor was not able to feel the presenting part. When the cervix is 5 centimeter dilated, doctor should feel the presenting part. It means the head was engaged. So when the doctor is not able to feel the presenting part, it is another terminology of saying the loss of station. So diagnosis is, here the diagnosis is uterus rupture. When they are saying false labor, no, it is not false labor. At 5 centimeter, it is not a false labor, it is an active stage. Abdominal pregnancy, no, it is not abdominal pregnancy, because it is not an abdominal pregnancy, because in cervix would have not been dilated 5 centimeter. It is not an abruptio placenta, that we will rule out after a few minutes. The next question is, lady with 37 weeks pregnancy, previous cesarean, comes with low BP and tachycardia. Okay, now the lady is at 37 weeks and the lady is previous cesarean. Okay, comes with low BP and tachycardia. The first indication they are giving is hypotensive shock. Okay, on ultrasound, fluid is present in the peritoneal cavity. Fluid is present in the peritoneal cavity. Okay, diagnosis and treatment. So now they have told you that previous cesarean patient has got at term has got into the hypotensive shock, and now there is fluid in the peritoneal cavity. What is the diagnosis and treatment? So here the diagnosis and treatment is the diagnosis is uterine scar rupture. The previous scar has ruptured, that is why there is fluid in the peritoneal cavity, and that is why the patient is going into the hypotensive shock. And the treatment, as I already told you, is the the laparotomy. We have to open the peritoneal cavity, approach the peritoneal cavity and stitch the uterus and create hemostasis. Now the other options are laparoscopy for both diagnosis and treatment. As I already told you many times, laparoscopy or the general anesthesia procedures are not done in a unstable patient. For a patient to give you general anesthesia, patient should have stable vitals. GA or laparoscopy procedures are not done in the unstable vitals. Okay, next is ectopic pregnancy at 37 weeks. It is not ectopic pregnancy, never. Okay, eclampsia and LSC is, as there is already written, low BP and tachycardia, so it's not an eclampsia. Okay, so no queries. Now let us see the abruptio placenta. What is abruption placenta? Abruption placenta is that, I have already explained you once again for you all, the spiral arteries which are supplying the placenta, they tear, and then the blood, it accumulates between the decidua and the placenta. Soon that blood which has accumulated between the placenta and the decidua, it enters the myometrium. As a result, the uterus becomes tender and tender. Why it is tender? Whenever the blood will enter in a muscle, then the muscle will be tender. It is very difficult. Like for example, when we get a bruise whose the blood has entered in the muscle, we feel very pain, and that side becomes tender. In a similar way, when the blood has entered into the uterus myometrium, the uterus has become tender, and there is loss and pain abdomen. Okay, the second triad is painful dark colored bleeding. Okay, so now because of the tender uterus, the it will be painful, right? And as it the bleeding which is coming out of the genital tract is the accumulated blood. The accumulated blood is always dark colored. Okay, so you should know that accumulated blood is always dark colored. Number three, now you all know that fetus gets its supply from the all the nutrients, all the oxygen from the placenta. Now when the spiral arteries is teared, of course the fetus will go into distress. No, there's nothing new about it. So there will be fetal distress, either due to the, depending on what distress it is the fetus can go into the IUD, or decreased fetal heart rate, or loss of fetal movement, whatever is there. One thing is there, when the uterus becomes tender and there is pain abdomen, in that condition there is always loss of fetal movements. Okay, because that uterus is in so much of pain that the uterus cannot feel the fetal movement. Okay, so what is the abruption triad? Number one is the dark colored genital bleeding, or APH. Number two is pain abdomen or tender uterus, and number three is fetal distress. So this is the triad of abruption placenta. So whenever in the question you get 2 or 3 symptoms from this triad, then the diagnosis is abruption placenta. Once again, what is the triad of abruption placenta? Genital tract bleeding, pain abdomen or uterus tender, both are one and the same thing, and fetal distress. Okay, let's see the different questions which come from abruption. See, a hypertensive pregnant patient. So we all have studied hypertension is a risk factor of abruption placenta. Okay, came at 34 weeks with a history of pain in abdomen and bleeding per vaginum. So 2 symptoms of triad had come, and third is loss of fetal movement. Third has also come. On examination, the uterus is contracted and increased fetal tone. Okay, so uterus is contracted, that is what is uterus is tender, right? And increased fetal tone. Yes, increased fetal tone is a sign of fetal distress. And fetal heart sounds are absent. Why the fetal heart sounds are absent? Because of the fetal distress, right? The most likely diagnosis is, let us now rule out the other options. The one is placenta previa. See beta, placenta previa, there is always painless bleeding, as it is a pain bleeding with pain, so it is not a placenta previa. The second option is abruptio placenta. Yes, it is abruptio placenta. The third is premature labor. If it is a premature labor, then why there is fetal distress? Why there is a tender abdomen? Why there is increased fetal tone? Okay, are you getting my point? Why their fetal heart rate was absent? Right, so this is not the premature labor. And next is I have written the same option, but we can say rupture uterus. In the rupture uterus, there will be abdomen will be soft. There will be no increased fetal tone. Okay, because if now in the rupture uterus, the fetus lies in the peritoneal cavity. It is a dead fetus lying in the peritoneal cavity, so there will be no increased fetal tone, right? And of course, in the rupture uterus, there will be no bleeding per vaginum. So it clearly rules out the option. Next is pregnant woman brought to the emergency room with pain abdomen and hypotension. So this time the patient has pain abdomen and hypotension. On examination, there was abdominal distension. Fetal heart rate was not felt. Now see, the patient is in hypotensive shock. First thing. Second thing, there was abdominal distension. So abdomen is distended, or okay. So you can say there's some problem in abdomen. and the fetal heart rate was not felt. So now we have to make the diagnosis. So first is only two symptoms are present out of the triad of abruptio. So abruption can be, but where is the genital bleeding? See beta, in the abruptio, as you know, the bleeding is occurring between the spiral arteries. When the spiral artery tears, bleeding is between the placenta and the decidua. So it is probable that it is quite probable that the it can be concealed bleeding also. The bleeding is so high that the patient is getting the hypotensive shock. So due to that shock, due to that concealed bleeding, the patient is going into the shock. Okay, now let us see why it is not rupture uterus. It is not rupture uterus because in the rupture uterus, there are other signs like superficial fetal parts are palpable. There is fluid in the abdomen. There is loss of fetal station. So nothing such things are mentioned. So it is a diagnosis. It's not the rupture uterus. IUD, it can be IUD, but but the other features in IUD alone, if it is alone IUD, then why there will be abdominal distension, why there will be hypotension? Such features don't come in IUD. Obstructed labor, as I already told you, in obstructed labor the features are dry vagina, dehydration, such symptoms. So it is no doubt it's a case of abruptio placenta. Now the next symptom is a hypertensive patient at 34 weeks came with the history of pain in abdomen and loss of fetal movement on examination. Uterus is contracted with increased fetal tone. Fetal heart sounds are absent. The most likely diagnosis is. So now in this case, all the three symptoms, only the bleeding is not present. All the things are present, right? For example, there is a history of pain in the abdomen. There is loss of fetal movement. So it is the abdominal pain is there, and uterus is contracted and increased fetal tone. So this myometrium में जो ब्लड जाता है जिस वजह से यूट्रस टेंडर और इंक्रीज फीटल टोन होती है और पेन होता है, दैट इज द मेन सिम्टम ऑफ abruptio placenta. Okay, and here again they have not given the bleeding, but as you know that hypertension is a risk factor of abruptio. Such a things don't happen in placenta previa and premature labor. So again, after ruling out all the options, abruptio placenta is the answer. So in the case of the concealed bleeding of the abruptio placenta, sometimes they don't give you the option of bleeding. Now let us see the last option, last topic of the today, to differential diagnosis, scar dehiscence. See, when previous cesarean, patient it goes into VBAC. VBAC is vaginal birth after cesarean, or TOLEC, trial of labor after cesarean. They are one and the same thing. So when previous cesarean patient it goes for VBAC, or when we do the vaginal birth after cesarean or trial of labor after cesarean, then the patient has labor pain. Okay, then the patient has labor pains. Okay, now sometimes the scar is so thin that before the stage of the rupture, the scar starting separating. That stage is known as scar dehiscence. Okay, now at that time the patient feels suprapubic tenderness because the scar is separating. Now this tenderness is not in the whole uterus. This tenderness is limited only up to the pubic area, because you all know that uterus scar, the scar on the uterus during the cesarean is in the lower segment, and that is the pubic area. So now when the patient will feel suprapubic tenderness, which is diagnostic of scar dehiscence. Okay, now let us see how the question comes. 30 years old, gravida 2, para 1, live 1, previous cesarean at 38 weeks, came to emergency room with the complaints of pain abdomen. So this is the previous cesarean at 38 weeks full term. It has come with pain abdomen. So it can be that patient is in labor. Let's see what other thing they give. On examination, patient has labor pains. So we were right. Abdomen is soft. So it rules out abruptio placenta. Okay, but suprapubic tenderness, this word suprapubic tenderness means that it is a pain in the previous cesarean scar site. Fetal heart rate is normal, so it is not a rupture, because as fetal heart rate, fetus is not in distress, and there is no genital bleeding, and there is no genital bleeding, and there is the fetus is not in distress, and the abdomen is soft. Okay, and on the PV it is 3 centimeter and 60% effaced. Yes, that are the sign of labors. On the labor only, the scar goes into dehiscence. So most probable diagnosis and treatment is, as it is the case of scar dehiscence, because if scar will rupture, then this patient can go into can become scar rupture case. So to avoid that, we have to immediately do the cesarean. I hope the biggest confusion of your all is clear, how to differentiate between rupture uterus, abruption placenta, and scar dehiscence. All the important points I have given here. Thank you for being with me. Please like, share, and subscribe my channel. It helps me a lot, it encourages me a lot. Thank you. Thanks a lot.